Our next speaker is Dr. Stephanie Snow, who is a medical oncologist at Queen Elizabeth II Health Sciences Centre in Halifax. We learned of Dr. Snow through a patient who came to our first annual conference. And it's quite a story, which I'll just quickly talk about. His name was Philip, and Philip and his wife Charmaine came last year to our first conference because Dr. Snow had heard about our organization, and they made the flight from Halifax and joined the conference and joined the family. So we're really happy to have Dr. Snow here. As I said, she's a medical oncologist at QEII Hospital in Halifax and an associate professor at Dalhousie University. She treats gastrointestinal, thoracic, head, and neck malignancies. She has a strong interest in medical education, overseeing the Dalhousie Undergraduate Medical Oncology program and contributing to national oncology education initiatives. Dr. Stephanie Snow.
Thank you so much for that kind introduction, Teresa. And first I want to say it was a true honor to have been invited to speak this year at the meeting. I come from the province of Nova Scotia. We have a population of 1 million people. So it's very different than large centers like Toronto, where everything kind of funnels through us in Halifax for the most part. And when I came back from my maternity leave, which is now 3 years ago, when I came back, my head of our division said, Steph, I really want you to take the lead in gastric cancer. You're the only doc here that's also treating thoracic malignancies, which is where the esophageal cancers generally go. And the two cancers very much are intertwined in trials and biology and also the supportive needs. And I was really, really excited to learn a lot about this cancer, and I've had some great mentorship. Dr. Breslin-Maisley has taught me so many things about how to care for these patients, and it is an exciting time in cancer, medical oncology in general, but we're really starting to see some new treatments and ways to treat this cancer specifically. So what I'm going to talk about today are some of the newer data that we've had as medical oncologists for systemic therapy and treating gastric cancer over the past year, which will change our practice, and also looking forward to the future and how we can hope to continue to gain. Now, as I mentioned, we are treating with systemic therapy. So we treat for two intentions for our established standards of care. We help people be cured by treating those who have had a surgery and helping to reduce the rates of recurrence. So that's when we're fighting and really trying to keep this cancer away. But we also help other patients live with stomach cancer, those who have incurable cancer. And there our goals are not just to help people live longer, but also to live as well as possible. And it's a true honor to be able to participate with some great patients and hear these wonderful stories of our patients and to really walk down that road with them. And I was very lucky to walk down the road with Phil, and Charmaine is here today, and I'm thrilled to have seen her. And every day we meet new patients and help figure out how we can help them live the best life possible with this cancer. As I mentioned, there is some new data from 2018, and finally we will talk about looking forward to the future in systemic therapy, which is not all just chemotherapy. We use chemotherapy, but we also use some targeted drugs, and one thing that's very exciting in oncology in general, but also for stomach cancer, is the use of the immune system and immunotherapy I'll talk about today. So starting off in the curative intent situation, that's adjuvant and neoadjuvant. So those are just terms for insurance therapy. Neoadjuvant is given before a surgery, and adjuvant is given after a surgery. And there are different general practice patterns which can be kind of summarized globally. In the US, many patients receive treatment after their surgery using combinations of chemotherapy and radiation. We've already heard about some people today who've had that strategy. Many places in Canada and throughout Europe will use a strategy of a sandwich of chemotherapy, surgery, and then followed by more chemotherapy. And traditionally, we had used a combination of 3 drugs. We used to call that ECF or ECX. And more recently, most patients have been receiving a different combination of chemotherapies called FLOT. And that particular combination showed better outcomes for patients and is better tolerated in that more patients can get through the treatment. In Asia, where stomach cancer is very prevalent, including in Japan, they use an approach where they're just using chemotherapy after their surgery. So there is kind of a mixed bag of evidence. This is the research trial that established that FLOT regimen that I just mentioned in the pre and post-surgery setting, and it was compared to the standard. And what we found is the red line is the survival curve for those patients who got FLOT compared to those who got the previous standard of care chemotherapy. And we see that more patients are surviving over time. So that makes it a new standard of care. But what I want to highlight here is this is a comparison in the trial. So usually patients that go into trials are our fittest and our strongest patients. And in that red arrow, it highlights the number of people who actually made it through the post-operative component of the chemotherapy. And for our old standard, 37% of people only. And even for FLOT, which is better tolerated, there are still less than half of patients that made it through the chemotherapy. And it's great to see super survivors from surgery like we've just seen who look like $1 million. But a lot of patients are really quite sick, and it's a major surgery. And there are many people who don't get to that part of the chemotherapy. Now, this is the trial that established chemoradiation as a post-operative treatment. And this is very commonly done in America, also many places if you have your surgery up front. Some patients are ready to go to the OR right away, and some people have to go to the OR because they're obstructed. We just need to get that surgery done. The thing I wanted to highlight here, if I can't go back, can I? There we go, previous. Is that right down here on the bottom, this can also be a significantly tough treatment to get through. There was 1% of people who actually passed away complications from their treatment, but 73% of people had what we call a grade 3 or 4 side effect. That's a side effect that lands you in hospital or needs treatment in hospital. It's a serious side effect. So again, it can be a tough treatment, and these are all patients who have had surgery beforehand. So in terms of the new data from 2018, there was a new trial that was published. This was done in Europe. And what they were comparing here is the standard sandwich approach of chemotherapy, surgery, followed by chemotherapy, which is in the red bars along the top, with an approach that did the standard chemotherapy, surgery, and then chemoradiation afterwards. So kind of combining those two approaches. Now, in terms of efficacy, you can see these survival curves, so there's no real difference between those two approaches. But what is very interesting here is that regardless what the post-operative approach was, chemoradiation or chemo, it was a small number of people. Now here it's more than 50%, but not everybody made it to the post-operative treatment. We saw 62% and 59%. So the interpretation of the results by the authors was just this. Post-operative chemoradiation did not seem to be superior to the chemotherapy in this setting, but for both groups, it was hard to get people on the post-operative treatment. And I really think this is something that we see a lot as medical oncologists treating these patients. The implications of having had your stomach out, having gone through a large surgery with risk for things like infection, it can be very, very tough to get that needed treatment in to reduce the risk of recurrence. So I think that for the future, looking at ways of truly optimizing the pre-operative treatment strategies is very important. I've learned from Dr. Bresden-Maisley, she often gives all of her chemotherapy up front before the surgery. And I think that is a time when you can often get in there and get a lot of that systemic therapy, because if you have great control of the stomach, it doesn't do anything if there's already been some microscopic spread to other organs. And that's what we don't want to see, is people coming back with liver metastases, lung metastases. So I think that the theme from what we've seen this year is more evidence that the more we can do pre-operatively and get our treatments in to help improve survival, the better. Now, this is an interesting trial that is being run in Canada called Top Gear. It's also being run in Australia and other places. And here it's almost identical to the critics, but what they've done is instead of putting the chemoradiation at the end, they put the chemoradiation at the beginning. And so it'll be very interesting to see what this trial shows, because of course that was the intervention that was new in the critics trial, but a lot of people didn't actually get to the point where they could try that intervention. So if we do our chemoradiation beforehand, maybe that can actually show better survival rates. So we'll be looking out to see how this trial will read out. And I'm going to come back to this theme right at the end. So now in terms of advanced disease, this is when we're treating patients who we can't cure their cancer, and our goal is to help them live as well as possible and as long as possible with their stomach cancer. And that's exactly what I say to my patients. My job is to walk down this road with you. I wish you didn't have to walk down this road, but I'll walk down it with you, and my goal is exactly that, to help you live as well and as long. And I don't put it in that order haphazardly. My goal is to also improve your quality of life. And before we started our meeting today, I was speaking with Charmaine, and we talked about Phil. And Phil had incurable cancer from the beginning, and one of the biggest gifts we had is when I got him on chemo, for many months he could eat whatever he wanted again. He was so limited by the cancer, and because of that response, his quality of life went up. He got to have some excellent experiences and memories formed with his young girls, and that was so rewarding, even if I didn't help him live one day longer, which I think I did with the chemo, but that is in and of itself a very relevant endpoint. So all of these different bars are some of the different chemotherapy regimens that have been studied in stomach cancer, which is advanced. The backbone is usually based on a type of chemotherapy called fluorouracil. It can be IV or in pill form. And generally, we like to combine that with another type of chemotherapy, which is from the platinum family. Things like cisplatin, oxaliplatin. So the ones that have the oral 5-FU version, which is called capecitabine, are the greens, and then the blues have the IV. And so we can see that the median overall survivals we were achieving didn't quite meet a year. But those are some of the things that we use. And in general, we try to get a fluoropyrimidine and a platinum in for our patients, and what combination doesn't really seem to matter too much. In terms of second-line chemotherapy, when that first line doesn't work, we do know there's a role, but there's no great studies to say specifically you should use this or you should use that specifically in terms of a chemotherapy. And so we often use different classes that patients haven't been exposed to, most commonly a taxane group or an irinotecan. So this year, we found out about another line of therapy that we can add to our arsenal. If I can get this to go forward. Uh-oh. Close this. Can you get it back up? I can just open it again. Here we go. All right. Now I'll just skip ahead. There we go. All right. Sorry about that technical blip. Here we go. So this year we heard about a new study called Tang. So we first saw the first report come out at the World GI Cancer in the summertime, and most recently at ESMO, which is the European large cancer meeting, we saw an update. Now this is actually establishing a drug in the third line. So all of these patients would have had a first-line treatment and then a second-line chemo. So they had to have had a fluoropyrimidine, a platinum, and either one of that taxane or irinotecan. So they've kind of been through all the drugs that we know have activity in stomach cancer. And because there's no standard therapy after that, they were randomized to get this drug, which is an oral chemotherapy versus a placebo. And this is neat because it's a pill. And the red part of it is the actual chemotherapy part, and you can see it interacts with the DNA to prevent cells from growing. And the yellow part of the pill slows down the breakdown of that drug. And patients can take this without having to come in for an IV treatment. Now, we do have some experience using this already in colorectal cancer, and this trial established it also as having a role for stomach cancer. The trial included people with stomach and esophageal cancer, which is low down, what we call GE junction cancers, but the majority of them were gastric cancers at 71%. And here we see that in the third line, so a heavily pretreated group, there was a survival benefit with 21% of people making it a year out. And I'll remind you about that very first slide we saw, looking at the first line data. A lot of patients weren't making it out 12 months, and now we see in the third line. So this does seem to have a lot of activity. This graph shows the time until patients progress. And so that's a very meaningful endpoint because often when you progress, you start to get sick, your quality of life goes down. So the time is being delayed. And this was also shown in terms of response rates, but this DCR is disease control rate. And there was a disease control rate with this pill chemotherapy, 44%. So that to me is a very meaningful endpoint for a third line trial in stomach cancer. Now, truly in terms of functioning, as oncologists, we often talk about people's functioning as their ECOG performance status. That's how much you're able to get done in a day. And so once you're in ECOG performance status 2, you're still up and doing things more than half the day, but for instance, it would be really tough for you to go out and work and do those kind of things. And they looked at patients in this trial who already had a higher performance status, that of a 0 or a 1. They looked at the amount of time until they got sicker and fell into this ECOG 2, and it showed that they delayed that by a full 2 months. And so again, that's one of those endpoints that tells me that my patients are actually feeling better, having that better quality of time, in addition to living longer. So hopefully this is something that we'll be able to see soon, readily accessible for our patients. Now, we do have experience with this already in colorectal cancer. The most significant side effect is usually related to blood counts. And not many people in this particular group had consequences from the low blood counts in terms of infections or needing antibiotics, but that's just something that we kind of worry about as medical oncologists, and we just end up changing the doses. So it doesn't seem to have a lot of really bad side effects that take away from quality of life. So this was an exciting thing to learn about this year. Now, in terms of targeted therapy, what I've been talking about so far is chemotherapy. There are 2 classes of targeted drugs that do have activity in stomach cancer. There's HER2 for the subset of stomach cancers which overproduces particular protein, and there's drugs that target the protein. There's another group called angiogenesis, and those are drugs that don't target the cancer, but they target the chemicals in the environment around the cancer that help grow new blood vessels to the tumor to help it grow. And so HER2 is standard of care, as I mentioned, if patients do have this protein overexpression, which we standardly test for. And that's based on this particular trial, which was standard chemo plus or minus the targeted drug called trastuzumab. And we saw that patients lived longer. I'm scared to, I don't think it's going, maybe if I use the arrows, will be better. There we go. We saw that patients lived longer in the red bar where we added this medication. Now, the chemotherapy to which this was added was very specific. It was cisplatin and the oral 5-FU drug capecitabine. This year, we saw a meta-analysis that looked at the benefit of adding the Herceptin to different backbones of a fluoropyrimidine and a platinum. And especially since the drug oxaliplatin went generic and it's much less expensive, there's been a lot more uptake of a particular regimen called FOLFOX using oxaliplatin in Canada. And so what this trial told us is the top line there are the patients who are getting the trastuzumab, the targeted drug, along with FOLFOX chemotherapy, and they actually do seem to be doing better compared to those other regimens. So we were kind of extrapolating that anyway, but that gives us a lot more confidence now as medical oncologists that this is a very good treatment to combine. They use a lot more over the States where they have easier access to drugs, but a lot of us have shifted our practice towards FOLFOX. So this is very reassuring for that group. In terms of the VEGF, we have standard therapy targeting those blood vessel growth chemicals for second line. These were 2 trials that are positive. And what we commonly do for second-line patients is they get a combination of the taxane chemotherapy plus a drug called Romney Serum AB, which helps prevent those blood vessels from growing in. And this is the trial that established this. Now, what we were hoping was that if we moved that into the first-line setting, we would be able to also see a survival benefit. This year at GI ASCO, which is the big American GI meeting, we saw this trial called Rainfall. And what they did was standard chemotherapy plus or minus the drug Romney Serum AB. It did have a small improvement in what we call progression-free survival, the amount of time till we saw progression, but it was more statistical. It wasn't actually that much difference. It's 5.7 months versus 5.3 months. And in terms of survival, patients live the same amount of time. So this was disappointing. We were really hoping to see that if we brought this strategy into the first line, it would make a difference. And I think this reflects a really important thing, that not all stomach cancers are the same. There are many different subtypes of stomach cancer, and there's one called intestinal type that really probably is the type that's most likely to respond to these, whereas other types of stomach cancer may not get the same benefit. And so one of the other themes, as we're going to now talk about the future, is really trying to be as personalized as possible for our patients. We see how well our targeted drugs work when we personalize for the HER2 protein. Now, hopefully, in the future, we can get the best treatment for people's individual cancers. So in terms of immunotherapy, now this is a brand new concept for medical oncologists and oncology in general. All these other drugs, they target the cancer cells directly. Immunotherapy helps the immune system to target the cancer. Our immune system plays a very important role in identifying and destroying cancer cells. Sometimes it fails, just like sometimes it fails in fighting off bacteria infections, so you need to take an antibiotic. And this has really changed our standard of care for melanoma, kidney cancer, bladder cancer, lung cancer, head and neck cancer. It's a very long list. And there is activity for immunotherapy for some people with stomach cancers. There's one drug called pembrolizumab, and that one is already approved in the US, and it's based on some data that we're going to look at. And in Japan, there is a drug called Nivolumab, which was already approved as well because of a Japanese study that looked at this drug in patients. And these are two very similar immunotherapy drugs. This study randomized people who have already had previous chemotherapy to get pembrolizumab versus a standard taxane chemotherapy. And what we see here is a survival curve with a very interesting pattern. It's an X. I call these crissy-crossy lines. And that tells us that one group is doing better with chemo and one group is doing better with immunotherapy. And the immunotherapy arm is the green arm, and it does take a while, but as you get out beyond a year and a half, there's a group that's doing very well with immunotherapy, and that's something we've seen. If you respond to immunotherapy, you respond generally for a much longer period of time. It's what we call the tail on the curve. So that tells us we have to figure out who those patients are on the tail of the curve to make sure they get access to the drug. One of the ways we can figure that out is to look at a particular test called PD-L1. And these three graphs have broken that same population into different groups based on their PD-L1 status. And the group that's furthest over here are the positives, and we can see there's no longer a crissy-crossy line. You can see a clear benefit from the immunotherapy, whereas the colors are reversed completely for those who are PD-L1 negative. So that might be one of those clues. And we call those clues biomarkers. Those are things we can test to tell us who is most likely to respond, who should get what treatments. Now, this is where things got much more exciting. We looked at another biomarker called MSI Hi, and now we've bumped up the response rate to almost half of the patients getting a benefit. MSI Hi is a state where cancer cells cannot correct errors in their DNA. Patients with Lynch syndrome, by definition, have an error with MSI, but there are other people who have MSI that they've just inherited. And we see this across cancers, that if you have MSI high cancer, you accumulate a lot of mutations. And mutations lead to aberrant proteins, and that's what the immune system recognizes as a cancer cell. It's almost like the sign that says, hey, there's something wrong with me, and allows the immune system to go in for the kill. So regardless of what kind of cancer you have, if you're MSI high, you're very much more likely to respond to immunotherapy. Now, in terms of how many of our cancer patients with stomach cancer will fit into this group, as I mentioned, there's these 4 large groups of different types of stomach cancer based on molecular studies. And about 50% are that intestinal type that I previously mentioned that probably do well with targeted therapies. Another 20% are the diffuse stomach cancers that are often related to genetic syndromes. We have about 22% that are MSI Hi, some of which will have Lynch syndrome. And there's another 9% that are related to a viral infection called Epstein-Barr virus. Now, what we know, it's those 2 groups of Epstein-Barr and MSI Hi that seem to respond the best to immunotherapy. So if you add those 2 together, does that mean that 31% of our stomach cancer patients will do well with immunotherapy? Well, not really, because we're more likely to cure those patients with Epstein-Barr and MSI Hi cancer. They have a better prognosis and are less likely to end up in that pool of patients that we're treating without curative intent. So I think that's very important information, and we need to take that right back to the beginning of the curative intent and say, how can we try to improve cure rates? In order to try to show you that, I'm going to show you some slides that came from ESMO for a different type of cancer. But where we are right now is our current ways of classifying cancer are piling everybody together. And what we need to do is try to find ways to really target the right group. So our little benefits are not a few months here, a few % here, but to really target it on our groups to get better benefits. And to really try to find those what we call prognostic and predictive biomarkers to get the right treatments for patients. And the ongoing trials of patients in curative intent can really help shape that. So this was the trial I wanted to show you. These are patients with bowel cancer who are MSI Hi. And what they did was they identified the fact they had bowel cancer. They had a biopsy. On that, they tested for MSI Hi. And they gave them 2 quick doses of immunotherapy drugs. And they did that quickly before they went for surgery. There was a maximum of 6 weeks, so they weren't delaying surgery. And for those patients who are MSI Hi, look what happened to their cancers. We see first their staging before they went to the OR and got their immunotherapy. And then the second staging is how much cancer was left after just 2 quick doses of immunotherapy. We found that in the majority of patients, every single cancer cell was destroyed by the immunotherapy before they went to the OR. And those who had some cancer left, there was just 2% at the most. So I really think these are the kind of lessons that we need to take to gastric cancer. If we can identify these patients, these are the kind of trials that we need to be innovative and look at, because I can downstage lots of people with chemotherapy pre-op, but it's very rare that I get these kind of results. And if we can identify those patients and get that level of care in early, I think that's where we're really going to see many, many more patients coming in here who are true long-term cured survivors and less people who ultimately we have to help live with the cancer. And this is a picture of how much the colon cancers shrank down with that treatment. One last thing I want to mention is that those biomarkers, especially with immunotherapy, there's so much involvement of our gut health and the microbiome and the bacteria that live there that impact therapy for immunotherapy patients. We know that directly predicts in other cancers like melanoma the response to immunotherapy. So I think a lot of what we'll be studying is not just the cancer, but the environment, looking at things like diet. And in the future, we might even be doing things like stool transplants to help patients get better responses to therapy. So it's a very exciting time. So take-home messages. In order to cure, we need to focus on care that we can deliver, and that in many cases means maximizing our treatment in the preoperative setting so we can actually get it in. There is certainly hope right now. We've seen a new drug added to our arsenal this year. We've seen us able to finesse out better how to treat patients. There are many ongoing trials. But right now we're in a very exciting age where we have access to new technologies. It's much easier to do molecular studies that I really think are going to change future practice. And I think that left me exactly 5 minutes for questions.
So, wow. I was just diagnosed with colon cancer again. So first my stomach, and anyways, I have an opportunity to go on the blind trial for the immune. Is there anything out there where I can go on it where it's not a blind study? Because I know it's $18,000 a month and I don't have that.
So depending on where you're living, you are going to have access to different
Princess
trials.
Margaret.
Okay, Princess Margaret generally has the best access to trials, and we're a small network. So we often know if there's a trial open here that's open at a different center.
I am going in, but I don't want it to be blind. I want the $18,000 treatment.
Yeah. And so right now, this is a very exciting time. And for one patient, you often say, this is what I want. When we're doing these trials, we have to have that comparison in order to show that something is better. Without those two lines on the curve, we're never able to approach our governments to get funding.
Okay.
And so depending on what stage you are in the trial design, we can't just have one arm because we have to show that something's better. It's also very important to know as much as you can about your cancer. And so for some patients, they will just pay for the drug. And I had a lady with stomach cancer who had seen some of the data on pembrolizumab. She said, I'm just going to pay for it. And she did pay for it.
I don't have it.
And it didn't work.
Okay.
And when we look at all comers, the response rate to immunotherapy is about 10%. Okay. And so being able to be as smart as possible as doctors and say, okay, you're somebody who's got the 50% chance versus a smaller chance, help us make the smartest decisions. Okay. So some people will look into whether or not they're able to get the genetic testing, more information on their cancer. Right now, I do send my patients with advanced stomach cancer to get that MSI Hi testing done. It's not an expensive test. Our hospital will pay for it. And then if I know they're MSI Hi...
I do believe that's what I'm getting tested for.
Okay, great. So that will be very important to help you know what the chances of response are.
Okay.
And then my job is when I test, if it comes back positive, then I have to find a way to get a trial or get access for my patients. Okay. I had a lovely patient who's not mine anymore because I put him on a trial in Montreal. He was willing to travel. And he's had a complete response to pembrolizumab, and he continues to be followed in Montreal, and every once in a while he just drops by to say hi. And so we have those super success stories. Unfortunately, it's not the story for everybody. And outside of participating in a trial, unless you're super, super rich, sometimes that's the only way to even have a chance of access. But that's what we need to bring the science forward. So I definitely follow up on that conversation with your oncologist as to whether or not that testing has been done and what that means for you.
Okay. It's going to come back in 3 weeks, so I don't...
Okay.
Yeah. Okay, thank you.
Good luck with your experience on the trial.
Hi, I'm just curious if there's been any trials for diffused cancer in relation to immunotherapy.
So diffuse cancer is really one of the toughest things that we face. Patients living with diffuse cancer and us treating them, they do seem to be the group that seem to be the most resistant to all of our therapies, targeted therapies, chemotherapies. That is a separate group than those that we talked about, which are the Epstein-Barr virus related and the MSI Hi, that are the ones that are highly likely to respond. There are some patients with diffuse gastric cancer that make it into those trials, but because diffuse gastric cancer can often be more aggressive and the patients are more sick, they're generally underrepresented in trials. Because to go on to a trial, you have to be fit. You have to have a good performance status, and often diffuse patients, it's all we can do just to try to get them onto something because they're quite sick. And so they are underrepresented. I don't think that this is going to be the home run for diffuse. I think it's going to be an answer for those other subsets. But that's where we have to look in the future. Is there something we can modify? Be it the gut microbiome? Is it combining immunotherapy with something else? The single immunotherapy doesn't seem to be the home run there. But what we need to do is keep pushing the envelope and saying, what can we do to make non-responders into responders?
Hi, sorry, you didn't mention this, but I'm just wondering, do you know anything about HIPEC?
So HIPEC is a procedure where there is spread that's inside the abdominal cavity, and certainly Dr. Swallow might be able to speak a little bit better to this than myself. And then there's chemotherapy that's actually put in the abdominal cavity. It's a very aggressive treatment, it's a very intense treatment, and it's for highly selected patients with a very minimal volume of disease. It's mostly established in other forms of GI cancer, something like colorectal cancer. In gastric cancer, there often is spread to that gastric area, and so for very fit patients, we will send to specialized surgeons like Dr. Swallow. In Nova Scotia, for myself, I'd send them to Dr. Porter for a discussion. It's not something that's a standard treatment for most people, but I think there are some people that can do well on a kind of one of, but we don't have those kind of survival curves that I showed earlier. And I think that Dr. Swallow certainly might be able to speak to that better as the surgeon. I have sent some people for it. Okay, well, if there's no more questions, thanks again for this opportunity to speak.